to give you the lecture concerning the management of anorexia. And as you see on the first painting, there is the picture which is 400 years old, depicting the malnutrition and depicting the atmosphere of depression and sadness. So, speaking about the problem of anorexia, we oftenly, especially practitioners, using misleadingly the term of anorexia or cachexia as the homonyms, and usually minimalize the phenomenon. So, is the cancer anorexia cachexia syndrome, is it a myth or reality? And speaking frankly, is the real clinical problem. So, what is the definition? Speaking, precisely. So, anorexia, it is the loss of desire to eat. It may be caused by decreased or a complete loss of appetite that may or may not be related to treatment-related nausea, vomiting, oral pain, diarrhea, and loss or disturbance of taste. So the presence of anorexia could be characterized by more effectively by identifying objective symptoms, including early satiety, taste alteration, and nausea, and by assessing its severity. Anorexia-related symptoms like weakness, fatigue, depression, tooth loss, organ damage have a negative impact on the health status, related quality of life, and also affect patients' ability to perform daily tasks. So, and it can result in death. And Hakim, contrary to what you said at the beginning about the side effects of the drugs we are using treating metastatic renal cell carcinoma, it has to be stated that 60% of cancer patients, they do have anorexia despite the fact that they are not receiving chemotherapy. And anorexia can be produced by the tumor independently of that produced by the treatment. So, right now, the definition of cachexia, it is really old. It became from the Greek words kakos and hexi, what means bad habit. And the first definition came from Chambers' encyclopedia 100 years ago. And it's described as chiefly used in regard to chronic diseases where the general nutrition is defective and the blood in an unhealthy state. Thus, cancerous cachexia indicates the peculiar impoverished state of the blood and general debility which are associated with the deposits of cancer in various parts of the body. What about today? The modern definition is that cachexia is multifactorial syndrome characterized by an ongoing loss of skeletal muscle mass with or without loss of the fat mass, it's very important, that cannot be fully reversed by preventional nutritional support and leads to progressive functional impairment. Its patophysiology is characterized by a negative protein and energy balance driven by variable combinations of reduced food intake and abnormal metabolism. According to a novel European consensus published recently in Lancet Oncology, we today divide the cachexia into 3 stages. And anorexia is placed on the first stage, or precachexia. And it's the state when we do observe the weight loss below 5% with anorexia and metabolic change. The clinical, fully developed cachexia is the state with the weight loss over 5% or the BMI below 20 and weight loss over 2% or sarcopenia and weight loss over 2%. Which are often accompanied by reduced food intake and systemic inflammation. Finally, the refractory cachexia is the final end stage of disease, and with very low performance scores, patients' performance scores, and usually the expected survival of patients at that stage is below 3 months. So also the anorexia frequently accompanies cachexia. There does not appear to be a cause-effect relationship between the two. Anorexia may worsen cachexia in patients also in RCC. What's the pathophysiology? Usually the organ responsible for the appetite regulation is located at arcuate nucleus in hypothalamus. And there are two possible ways of contacting the peripheral world and the signals coming to that nucleus, and then behavioral effects regulated by this organ. So there are two possible ways of influencing the activity of hypothalamus. One is anexogenic, and the second one is prophagic. The first one, the prophagic, it contains from the biological complex which contains the nucleotide Y and agouti-related protein, and those which is responsible for the anorexia-genic effect. It's constituted from the prom and card. So during the cancer, tumor-host-immune interaction leads to neuroimmune activation, and anorexia this way is mediated by inability of hypothalamus to respond appropriately to peripheral signals indicating an energy deficit, like pancreas-derived insulin or the stomach-derived ghrelin. Some of the cytokines like IL-2 or TNF-alpha, they do mediate hypothalamic resistance. And as you can observe here, increased brain cytokine expression disrupt the hypothalamic mediated satiety via increased serotonin synthesis and its release. Contrary, the cytokines, they are inhibiting NPY-AJRP neurons, which mediate appetite. So how do we can assess it in clinic? We do have different scales, like Edmonton, like 18-item measure factor, MSAS, it's a memorial scale. And then we do have a lot of clinical parameters which can characterize the loss of appetite. As you see, we do have demographic characteristic, the routine laboratory values, the risk of symptoms who correlate, as you see, perfectly with, they are highly statistically significant with the state of lack of appetite. And same with correlation of appetite level with ratings of other symptoms. And finally, we do have data which are really stimulating. This is a prospective study from Veterans Administration showing the differences of survival between those who have no weight loss and normal appetite, in contrary to those who has no weight loss, but they do have lack of appetite, and both weight loss, normal appetite, and weight loss and lack of appetite. And survival is statistically significant much longer for those who have no weight loss and normal appetite. What about the drugs we are using in metastatic renal cell carcinoma? They can generate anorexia between 14 to 37% for all of the inhibitors, monoclonal antibodies. So they can influence on patient status, but some of them, they can do much more. In case of sorafenib, despite this deceptively high body weight, patients with RCC have high prevalence of advanced muscle wasting while treated with sorafenib. And it's more than 50% of patients, they do meet sarcopenia criteria. So here you can observe the effect of sorafenib of muscle body, which is red after initiation of sorafenib, and loss of subcutaneous blue and visceral yellow adipose tissue in long-term sorafenib-treated patients. So how to treat them? We can use corticosteroid, we can use megestrol acetate, but as in case in steroid, we can improve appetite over only a few days. The longer treatment with progesterone acetate doesn't influence the body weight. As you see here, this is the list of drugs we can use treating anorexia, and most of them, they do not show any effect. So what can be done if we do have an evidence on level 4 that those drugs are not working? So one of the promising trials is the combination of megestrol acetates altogether with novel olanzapine drug. And as you see at the bottom, after 4 and 8 weeks, they increase the appetite and also many other parameters here. The blue color is 4 weeks and the red one is the 8 weeks. And all of the elements of anorexia, they are strongly improved after such a combined treatment. So what about results from other clinical trials? Most of them, they are saying that and stating that studied drugs, they can improve appetite for the short time, but they do not influence the patient's weight. Some of the trials, they are right now, and some of them, they are interesting, like drinking red wine. This is a Mayo Clinic study, and olanzapine, which is, I mean, right now should be finished. So what about the perspectives? I guess the hope is in molecular biology, and one of the most intriguing targets is MYC1. It's a multifunction macrophage inhibitor cytokine 1, and its expression levels, they are substantially increased in cancer cells, serum, and cerebrospinal fluid during the progression of cancer, intracranial brain tumor, melanoma, lung, gastrointestinal, pancreatic, colorectal, prostate, and breast epithelial cancer. And many other facts, they support that it can be a crucial protein regulating the process of anorexia. So what is the final message? At first, that malnutrition in cancer patients is associated with the poor prognosis, whereas weight loss is an important predictor of mortality. Disease and treatments have a major impact on nutritional status, and by improving nutritional status, we can change the prognosis, quality of life, and functional status, facilitating improved tolerance to treatment. And the final one, I guess this is a time to speak about Memorial Sloan Kettering criteria, Cleveland Clinic Foundation criteria, which are describing the patient's status as the performance score using Karnofsky or WHO scale. Both of them, they are descriptive, not parametric measures. So maybe it's the time to replace them with more parametric lean body mass index, and the patient's weight. Thank you for your attention.